Well, I've learned something pretty important. If I don't keep these videos to 15 minutes or less, I have trouble uploading them. So that last one just kind of cut off, and I had to go back and listen to see where it was I ended up. And I started to say that tachypnea is an early sign of adult respiratory distress syndrome. And that's because, and we talk more about ARDS in the 4th semester, but the nutshell version is that ARDS produces a pulmonary edema that's not related to heart failure. Rather, it's related to the capillary membrane permeability increasing and allowing all kinds of fluids and stuff to infiltrate the interstitial and the alveolar spaces in the lungs, making it really hard for oxygen to get through. Actually, carbon dioxide is 20 times more diffusible in water than oxygen is, so it actually comes out, so the patient actually is able to get rid of CO2 initially, but they're having trouble getting oxygen in to the bloodstream, and so they will breathe more rapidly trying to get that oxygen in. So patients need to be assessed, their oxygen levels need to be assessed, and their blood gases need to be assessed. Adult respiratory distress syndrome typically requires intubation and mechanical ventilation, and then it runs its course with, hopeful resolution. Surgical intervention. Well, if gallstones are the problem, then gallstones need to be gotten rid of. If there's an uncertain diagnosis as to what is producing the pancreatitis, if the patient's not responding to conservative therapy, if they have abscesses for sure, pseudocyst or peritonitis, they may require surgical intervention. An example of a surgical or invasive intervention would be the ERCP, which we talked about when we did the gallbladder, and actually this picture comes out of the gallbladder information. And so it's a little bit misrepresenting. I would entertain the idea that everyone's anatomy doesn't quite look like this, that most people have a common bile duct that actually has some space to it, off of which the cystic duct and the pancreatic duct go. Namely, you could have a stone obstructing the common bile duct, which still allows for movement of bile coming down the cystic duct, this is the cystic duct here, to reflux into the pancreatic duct, and you don't get that here because, see, there's, you'd have to have a stone right here for that to happen, and I think that most people's anatomy has a little bit more room here. Another thing that can be done is an endoscopic sphincterotomy where they kind of open this area up, get the gallstones out. Patient may need a lap chole, or another surgical intervention that might be required for this patient would be a percutaneous CT-guided drainage of the abscess. In this situation, they may leave the drain in place. If that's the case, you need to be particularly concerned about that patient's skin because the enzymes and stuff that are in that abscess can be very irritating to the skin. After all, they're enzymes, and enzymes are designed to break things down. Nursing diagnoses would be acute pain, fluid volume deficit, imbalanced nutrition, ineffective therapeutic regimen management. This would relate to alcohol use. In health promotion, we're going to assess predisposing factors. We're going to treat gallstones and eliminate alcohol intake in this population of patients. Okay, now we move to chronic pancreatitis. Quite different from acute pancreatitis. This is progressive destruction of the pancreas, and the pancreatic tissue becomes replaced with fibrosis and fibrotic tissue. The most common reason for chronic pancreatitis is chronic alcohol. In chronic pancreatitis, you have continual inflammation with destruction of pancreatic cells. It may actually begin with an acute pancreatitis, especially the case in an alcoholic pancreatitis. Almost all cases in our country are caused by chronic alcohol use. Smoking cigarettes will accelerate the progression of chronic pancreatitis, much like high blood pressure accelerates chronic kidney disease. Cigarette smoking accelerates chronic pancreatitis. While gallstones may cause repeated bouts of acute pancreatitis, it is very uncommon for chronic pancreatitis to develop in patients who have gallstone pancreatitis. There are a few cases where there are other causes like hypercalcemia or hyperlipidemia. There is a familial pancreatitis that can develop. Also, trauma of a ductal stricture that develops during the process of healing can also produce chronic pancreatitis. But truly, these are rare. This is it, and this is an accelerant. Exactly how alcohol causes chronic pancreatitis is not clear. It's thought that these the pancreatic ducts are obstructed with protein that precipitates, causing inflammation and sclerosis. This is mainly in the head of the pancreas, and then that produces atrophy of the gland. Pseudocysts and abscesses are common in people who have chronic pancreatitis. Not a good thing. The clinical manifestations of chronic pancreatitis include abdominal pain. This abdominal pain will be located in the same areas as the acute pancreatitis. It happens in 95% of patients, this abdominal pain. It's deep in the upper abdomen. It radiates to the back. It's a heavy, gnawing, or burning feeling. It can last for days or weeks. It can actually disappear for several months, and then it returns again. The pain becomes more and more frequent, or as the gland becomes fibrotic and atrophies, the pain may actually go away. Dead tissue doesn't hurt. Patient may have GI symptoms like anorexia, nausea, vomiting, flatulence, steatorrhea, and diarrhea. They have thin, decreased muscle mass because they're not getting enzymes to aid appropriately with digestion. You do need a large amount of pancreas to be damaged before you see symptoms. We've got a phenomenal reserve of pancreatic exocrine function. So your malabsorption problems and your steatorrhea won't develop until about 90% of pancreatic exocrine function is lost. Your fat absorption is going to be more affected than carb or protein absorption. You know, remember that carb digestion is helped by salivary and intestinal amylase, and then protein digestion is helped by gastric pepsin and by peptidysis from the small intestines. Although there may be some protein malabsorption, you do have other places where enzymes aid in protein digestion. Vitamin malabsorption is usually not a problem because the water-soluble B vitamins are absorbed through the small intestine, and then your fat, interestingly, the fat-soluble vitamins don't need pancreatic enzymes for absorption. Many of these patients will develop diabetes, and it is an insulin-dependent diabetes because literally their insulin producers are destroyed. The islets of Langerhans are destroyed. There may be mild jaundice with dark urine, and I think we've also mentioned the steatorrhea. Serum amylase is sometimes elevated, but often it's in the normal range because much of the parenchymal tissue that forms these enzymes has been replaced by fibrotic tissue, and so you don't have amylase. If there's biliary obstruction, then the bilirubin and the alkaline phosphatases may be elevated. Mentioned the hyperglycemia already. Mild leukocytosis may occur because of an inflammatory response, and that also then is the reason why a sedimentation rate is elevated. Now the secretin stim test This measures the ability of the pancreas to respond to secretin. Remember that secretin is the hormone secreted by the small intestines, and you have it in partially digested food. So this hormone will normally stimulate the pancreas to secrete a high concentration of bicarb solution. And the point of that is for that fluid to neutralize stomach acid, and that's necessary in order for the enzymes to work. So the food that comes from the stomach is acidic. The pancreas puts out a bunch of alkaline, bicarb solution to neutralize that acid so that then the enzymes can work to break down food. So that's secretin. So what's done is secretin is given IV, and then they assess gastric and duodenal secretions. They collect them over a period of 2 hours. People who have diseases that involve the pancreas, one of those being pancreatic, sorry, you heard that phone, right? One of those being chronic pancreatitis. Others could be cystic fibrosis or pancreatic cancer. They will have reduced volume of secretions and a reduced bicarbonate concentration in response to that secretin. Namely, you give secretin, bicarb solution is supposed to go up. In chronic pancreatitis, you give secretin, and bicarb doesn't go up in the gastric secretions that are evaluated. X-rays can produce, can visualize, you can see stones. And the ERCP allows for visualization of the duct system. And then stool samples will be examined for fecal fat content. If you don't have proper enzymes, then you have more fat in the stool. Hence, that's the steatorrhea. Okay, we'll take a break.